As you heard, dear colleagues, today we will talk about clinical application of vestibular evoked myogenic potentials in clinical practice in diagnosing patients with vestibular and also audiological problems. I will first speak about some foundation of a test and theoretical knowledge on which the test is based, and later we'll see how this can help us in resolving some practical cases. All of you are very well familiar with vestibular tests you perform at your office, diagnosing patients with vestibular problems. Most of them test lateral canals like caloric test and other semicircular canals like VHIT test. But what about otoliths? Can we test this part of the labyrinth? Yes, we can. And despite these sensors are sensitive to linear acceleration, we can measure their function just by sound. And here it's how it looks like. First, we see here is the section from Shuknet textbook where we can see where the utricule is and where's the stapes foot plate is. So really close each other. And from Courtois micro CT scans, we can see how it looks like in 3D space and what's the relation between stapes foot plate and utriculus. So here we consider actually utricule as a trampoline. So it oscillates with the same frequency as the stapes foot plate. So that's the main idea. How can we stimulate vestibular sense, otoliths, sorry, by sound? And here, just to remind you how utricule looks like, at the middle part, we have striola, and striola is full of type 1 receptors. Type 1 receptors have a short, stiff cilia, and on deflection, they react very fast. So they're really good transient detectors. On the other side, type 2 receptors have very long and flaccid cilia, and they have a slow response on deflection. So these receptors are responsible for sustained response. Here are results from electrophysiological measurements where we stimulated inner ear with bone conduction vibration and also by sound through air conducted. So upper part show response from type 1 neurons, which are innervated with irregular vestibular afferents. And as we can see, they actually respond really well to the vibration, bone vibration, and air conducted sound. But type 2 neurons, which are innervated with regular activity vestibular afferents, don't respond to change in a bone vibration or sound. So how can we know that the response which we measure is not from cochlea? How we know it's from vestibular part? And here are some studies which demonstrate that we can record vestibular evoked potentials in the patients with a deaf ear. Also, we can't get VEMP response in a normally hearing ear, but without vestibular function. Example are patients which gone through vestibular nerve section, so we definitely know that they don't have vestibular function at that ear, and we don't get response at those patients. Also, how do we know that other proofs that we actually test type 1 irregular neurons at striola? We got it from extracellular recordings and also histological tracing. And here is the reflex arc. At the beginning, when we start to introduce VEMP, we use just VEMP testing, and it was considered for measuring at the neck. It was a cervical VEMP. Later, the OVEMP is introduced, so now we do both tests usually. And CVEMP is actually inhibitory reflex, which is ipsilateral. Ipsilateral means if you stimulate the left ear, you measure at the left sternocleidomastoid muscle. And the vestibular CVEMP represents response from a sacculus. Mainly, the stimulation of a sacculus gives the response for a CVEMP. On the other side, OVEMP is excitatory reflex, and it is recorded contralaterally. If you stimulate the right ear, you measure it under with electrode under the left eye, and it represents activity of utriculus. And the place where we measure, actually, we measure the function of inferior oblique muscle. And here are some technical issues. For obtaining good CVEMP response, it is necessary to have a good contraction of a sternocleidomastoid muscle. It's because, as you heard, this reflex is inhibitory. So the muscle at the beginning of a test have to be really good contracted. And OVEMP, to get a good response, is like you see on this picture. This lady is looking upwards, so it's important for patient to look up to get a good response. And what about frequency? We use 500 hertz for CVEMP, but for OVEMP, it's better to try with 750 hertz. We got a better response. And also, to tell you, if you don't get a response with those frequency, it's worth to try to shift a little bit up or down, and to be sure if there is a response or isn't. Also, electrode placement is important, and I prefer to put the reference electrode on a tip of a nose. It's a place where you can get a better amplitude, better response when you perform OVEMPs. Here is one study which actually documented that. Now we are moving to clinical utility of this test. You see this chameleon, and I put it there because you know the symptoms of a patient with semicircular canal dehiscence really vary a lot between patients. So it's frequently difficult to recognize it on the basis of a patient history. But as you see here, the knowledge from year to year is growing. And now we actually know the mechanism of hearing loss in patients with a third window lesion. The hearing is actually diminished because the acoustic energy dissipates through the dehiscent through the dehiscence, so the air conduction thresholds are bigger. And on the down graph, you'll see that the bone conduction the thresholds are actually better than the normal. And the explanation for that is since the dehiscence changes the actually increases impedance between scala vestibuli and scala tympani, which makes ear more sensitive to bone-conducted sounds. And this is explanation how dehiscence affects our balance. Since here is dehiscence and air conducted sound actually makes more endolymphatic flow. So here is a place of a less resistance. We say the impedance is lower, so the movement of endolymph is bigger. So the stereocilia bends more and actually makes this dehiscent canal sensitive to sound, which is in a normal ear isn't. So those patients frequently have a Tullio phenomenon also. That means some kind of a vestibular sensation for sounds. And here are usual symptoms of a third window lesion, which are oral fullness, autophony, and tinnitus. And vestibular symptoms are usually dizziness, some kind of a disequilibrium, and as I mentioned, sound-induced vertigo, pressure-induced vertigo. And here how this third window makes vestibular hair cells more sensitive to sound. As I explained previously, the displacement of stereocilia is bigger, more cells are stimulated, and also this receptor cells of cupula, which are normally not sensitive to sound, they become sensitive to sound also, and all of that result in a much bigger amplitude when we measure VEMP response. And the thing I spoke a lot about this particular diagnosis, semicircular canal dehiscence, which is actually leading utility of VEMP testing, is because this is frequently in clinical practice underdiagnosed pathologies, since, as I mentioned, there is a great variability of symptoms among patients. And well, I can tell you, I started to perform VEMPs in 2010 when I acquired equipment from Neurosoft, which I still use today, the same device. It is really good. And later, I think it was 5, maybe 6 years ago, I started introduced in my practice OVEMPs also. And what is a good thing, it's the software is really good, a lot of very practical things, and the software is updated annually, so I can recommend you that. And what I was mentioning, that in order to diagnose patients with dehiscent ear, as we mentioned that the amplitude is bigger, so we can measure a threshold. So in the dehiscent ear, threshold is lower. And here are old criteria which are dedicated to measuring the threshold. What's wrong with it? Actually, we know that with the VEMP, there is great variability among patients, and also in the same patient, there is some variability between left and right ear. So here are some cutoff values suggested by several authors for threshold level, which we see that vary, and also the sensitivity and specificity vary a lot. And the pitfalls for measuring threshold are it's time consuming, also very exhausting to a patient. And as I mentioned, it is difficult to interpret depending on the cutoff values. What are new criteria? Well, actually, since we introduced OVEMP, we noticed that when we measure OVEMP, then the asymmetry is much, much bigger. The values we get from OVEMP measurement are sometimes 10 times and more larger than normals. This is a suggested value, 70.1 microvolts as a cutoff value when performing OVEMP, as you can see, with great sensitivity and great specificity. Also, normal ears are not sensitive to high frequency to get the VEMPs. With, for example, 4 kilohertz in the normal ear, you can't get a VEMP response. But in the ear with the dehiscent, when we stimulate with a high frequency, we can get a response also. And here is the first example. You see the first graph represents a CVEMP, and you see a little of a asymmetry. You see a bigger amplitude on the left side. Can we conclude it is significant asymmetry and suspect dehiscence? But look on the graph next to it. It is OVEMP, and you see how much bigger asymmetry we get, how big response we got with the OVEMP measurement. The values on the right side, which looks pretty much as a straight line, I have to change the values in the right corner in order to amplitude and get in the window so we can see it here, and the other side also almost look like a straight line. But if you see the values, it is 4 microvolts, which is normal value for OVEMP amplitude. But on the opposite side, it is more than 10 times bigger. Almost the amplitude is almost as big as we usually get when we perform CVEMP testing. And look below how it looks like if we stimulate with 4 kilohertz. On the non-dehiscent ear, we don't get any response. But on the side with the dehiscence, we still have a big amplitude, big response with CVEMP and OVEMP also, which actually confirms this diagnosis. And here is first example. This is a 41-year-old male. He complained about some kind of a strange sensation in the left ear, like some kind of a pressure. And when he speaks, he noticed that he can hear some kind of a echo. And when he shouts, he had a really strange sensation, some kind of a mechanical movement inside the ear, some kind of a jerking in the left ear. At the open space, he complains about some dizziness, and he didn't have any history of a head trauma. It is really important how you interpret patients' symptoms. The first one, oral pressure, oral fullness, is simple. The feeling of an echo is actually autophony, but the third symptom, like some kind of movement in the ear, I would interpret as a Tullio phenomenon. And here's his hearing audiogram, which looks pretty much normal, some kind of a mild hearing loss bilaterally. So his complaints about left ear, but if we compare left hearing with the right hearing, there is no much difference. It looks pretty much the same. And here is one instrument which I prefer at my office. It is a tuning fork, and I find it rather very useful, especially in those cases. And at this particular case, the Weber lateralized to the left side, and it is often worth to try and to see if patient can hear tuning fork from distant places. For example, from a wrist, here, put it on a bone. Of course, everybody will feel vibration in the hand, but most of normal ears can't hear a sound, but the dehiscent ears frequently can hear a sound from a distant places. Since we know that the bones are really good conductor for a sound. And here is a result of a VEMP testing in a presented patient. And of course, first we see the CVEMP response, normal out of the right side, a little bit bigger amplitude at the left side. But again, look at the OVEMP, how much bigger asymmetry is, how big amplitudes we get on the ear with the dehiscent. And again, if we stimulate ears with the 4 kilohertz on the non-dehiscent ear, we will not get a response, but we have amplitudes, normal amplitudes with stimulating ear with a 4 kilohertz. Here, on the non-dehiscent ear, you have a one wave here, but when we repeat, we don't get it. So any electrophysiological measurements like ABR or VEMPs, we all know that we have to repeat it at least twice to get, as we call it, a reproducible response. If it is not reproducible, we can't say we got the response like in this case. And here is a CT scan. CT scan actually confirms dehiscence, and here is superior semicircular canal, which is widely opened, and on this coronal section, we also see that there is the upper part of a canal is open. I mentioned Tullio phenomenon today, but in a clinical practice, don't expect that patient will have Tullio phenomenon like it is described in textbooks. Patient will not come and have, say, I have a vertigo when I hear some sounds. And if you ask patient, do you have vertigo to specific sounds? It is important, like when you're taking a history, to ask a patient to describe what he feels in his head and body when he is exposed to some sounds. Here is an example. This is a 47-year-old woman, and for 18 years she have a constant feeling of decaying, a very strange sensation and description of a vertigo. And when she gets up, pulls her to a side, and we have data of head trauma 24 years ago, the X-fall on her head, and also 7 years ago, the hearing progressively diminished at the right side, and also accompanied by tinnitus. And when I asked about specific sound, then she reported, since she lives next to the train rail, when the train passes or in the garden when the dog barks, she senses pressure in the head, and then she starts to disappear from head slightly to her feet, foots, and then she feels like she is not here, and then gradually she starts feeling she's returning gradually from foot to from feet to the head. And this was interpreted from our colleagues as some kind of psychiatric comorbidity in that particular patient. But if we consider our vestibular sense as something which help us to know where we are, and also to know that we are in our body, that we lives in our body, then we can better understand some vestibular disorders which shift us from that we don't feel actually we are in our body, and especially if it comes to the vestibular part which is connected to a feeling of a gravity. And here is hearing audiogram from that lady, and we see mixed hearing loss at the right side and almost normal hearing at the left side. Since it was a long time ago, at that time I performed just CVEMP, and you can see CVEMP response in the lower part of this slide. And what we can notice, does she has the response? Yes, at both sides. And is it as asymmetrical? No, pretty much symmetrical. What's wrong with it? Well, actually, how can we get to response with hearing with great conductive hearing loss? Here at 500 hertz is 40 dB air-bone gap at 500 hertz, but we get a response. If it is middle ear conductive hearing loss, so stimulating with the sound diminishes to passing because of a conductive problem in the middle ear, so not enough energy to stimulate stereocilia and no response. But if you get a response, I mean VEMP amplitude in ear with conductive hearing loss, that means that hearing loss is actually cochlear conductive, or as we say, inner ear conductive hearing loss. So actually the presence of a VEMP response in an ear with conductive hearing loss is very suspicious for dehiscence. And of course, this is a CT scan which confirms dehiscence of a superior semicircular canal in right ear. Here is an example of a male, 35 years. After boxing, actually it was some sparring, he was hit in the head, and after that he complains of oral fullness at the left side. No, it was not accompanied by tinnitus, no vertigo. And here is his audiogram, and we can see rather big hearing loss at the left side. But look at the right ear. It doesn't look like normal hearing. But that patient doesn't complain about it right ear. He has feeling that of normal hearing at the right side. When I ask about previous hearing, he knows from a teenage period that he had a slight hearing loss at the left side, but this man works at police force, and you know, when you entering police force, there are really strict criteria about hearing loss. So with that kind of a hearing, he couldn't get into police. So probably at that time he heard better, but he was told that at that time there was some hearing impairment at the left side, but I didn't see that that audiogram. So actually, we have here history of a head trauma, oral fullness at the left ear, and probably that represents deterioration of a hearing at the left ear. It's strange, not accompanied by tinnitus, since it's acute, and can help us. Can VEMP help us to solve this case? On the right ear, we got normal response. On the left ear, also, let's say normal response, but much bigger amplitude than on the right side. Which diagnosis should we suspect? Some kind of a third window lesion? Well, he doesn't have any dehiscence in semicircular canals, but he has a wide vestibular aqueduct. This is vestibular aqueduct, and it should be wide as this line here. This is posterior semicircular canal, and vestibular aqueduct should be less than 0.9 millimeters, but here is 1.6 millimeters, so it's wider. And we know that in cases with pretty good hearing until adulthood, we can expect deterioration of the hearing, especially after head trauma, which in this particular patient was the trigger for deteriorating hearing at that site. And I pulled out from my database, found 10 patients with enlarged vestibular aqueduct. In 8 of them, I did CVEMP, and in 7 of them, OVEMP. And here are results. Actually, as we expect, consider enlarged vestibular aqueduct as a third window lesion, we would expect pretty much similar results like in canal dehiscence, but I didn't get like that. In some patients, I got a normal response. Here is a CVEMP, normal and symmetrical response in 6 of 8 years, and but 3 of them had a conductive hearing loss. In one ear, there was bigger amplitude at the affected side, as this patient I showed you, and in one it was absent. When we go to OVEMPs, the response was absent at 5 years. We got a much bigger response in 1 year, in one patient, and one had normal response. So here we see that the finding of a VEMP is not so straightforward as it is in a third window lesion like dehiscence. The results are a little bit different. And here I would consider maybe CVEMP as a better predictor than OVEMP. And you go to a next case. This is a 66-year-old woman. She had acute vestibular syndrome, acute vertigo during the night with vomiting and also instability. In other couple of days later, in other institutions, she was diagnosed as having a BPPV. But when I saw her 3 weeks later, she still complained about slight instability and also slight oscillopsia and vertigo with abrupt head turns. It looks like some kind of the history for me looks like vestibular neuritis, but no nystagmus, head impulse test and it was normal, positional tests were negative, caloric test good, symmetrical response, CVEMP normal amplitude, normal hearing, no central oculomotor signs, and MRI exclude any central pathology also. So what can be concluded? While I was talking to that lady, I noticed really strange position of her head. She had lateral pulsion of a head, and it was worth to test utricle also. And here, subjective visual vertical was deviated to the left side more than 3 degrees. And when we measured OVEMPs, normal response at the right ear, but very low or absent response on the opposite side, on the left side. So what can we conclude here? Utriculitis, a form of partial vestibular neuritis, a little bit rarer form of vestibular neuritis, is actually manifested with ocular torsion, head tilt to head tilt, and we can document it by absent or response, and we also, as you saw, can do subjective visual vertical also as a measure of ocular torsion, and also measure of utricular dysfunction. Here is other case. This is a young male, 30 years, also presenting with acute vestibular syndrome. It started 7 days ago. No spontaneous nystagmus. Function of horizontal canals were normal, head impulse test normal, and caloric test, as you can see here, pretty much symmetrical response. No signs of central vestibular pathology. And you see hearing, drop in the high frequencies at the right side, not normal for 30 years old male. Here are results of a CVEMP. No response at the right ear, but very good and normal response on the left side. Also, as we can measure function of all 6 semicircular canal by VHIT, we got reduced VOR gain at the right posterior canal. You can see with the big covert saccade. So that's example of the right inferior vestibular neuritis. And frequently in those patients, we have simultaneously at the same time drop of a hearing at the high frequencies. So here is the clinical utility of VEMPs in vestibular neuritis. If we don't get response with OVEMP and CVEMP, we consider the whole vestibular nerve is affected. If CVEMP is preserved, it is more common form of vestibular neuritis, superior vestibular neuritis. And here in the literature, we can find some rarer forms when just some sensors of the labyrinth are out of function. We saw example of a patient with inferior vestibular nerve neuritis, which we consider just 5 to 10% of patients with vestibular neuritis. CVEMP is absent, but normal caloric test, which measure lateral canal function. And pay attention, patients with inferior vestibular neuritis in acute phase can mimic stroke. Acute vestibular syndrome, but head impulse test is negative, since lateral canal works, superior part of vestibular nerve works. And those patients have a spontaneous torsional downbeat nystagmus, which pretty much looks like a central nystagmus. Okay, what about patients with Meniere's disease? In the beginning of Meniere's disease, because of high drops, we can consider that, let's say, irritative lesion, and when we stimulate here by a sound, we can get augmented response. So sometimes at the beginning of Meniere's disease, some ears can show greater sensitivity to sound. But later on, most patients with Meniere's disease got absent VEMP response. Also, you can try to perform glycerol test. It is old test when after application of a glycerol, eye drops diminish. So after that, the hearing is better, and also we get a bigger response at VEMP testing. But I find it time-consuming and not very so important. I don't perform it, but I know some colleagues who does it. And also, OVEMP's results are abnormal also in almost 50% of Meniere's ears. And here is a study which demonstrated by MRI endolymphatic eye drops and measured VEMPs. So as you see here, this is the first graph is vestibular eye drops, the second is cochlear eye drops. So in vestibular eye drops, 10 years present a VEMP response with no eye drops, but also we got free absent response despite no eye drop. With significant eye drops, the number of cases with absent response was much bigger, but also in some cases we could get VEMP response. So here we can see it is not so, it varies a lot and the sensitivity is not great. We all know that Meniere's disease and vestibular migraine are somehow connected, and frequently it is difficult to differentiate if it is vestibular migraine or Meniere's disease. And as we know that Meniere's disease is inner ear problem, we can maybe use VEMPs to help us to discriminate these two disorders. But the frequency of a pathological VEMP response in vestibular migraine is not so low. There are two types. The amplitude can be reduced or sometimes absent, and also the latency can be prolonged, which is much more a rarer phenomenon, and if we consider it as a central problem. But frequency shift, for example, is characteristic for eye drops. But the conclusion is actually VEMP testing can't help us to distinguish patients with vestibular migraine from patients with Meniere's disease. What about vestibular schwannoma? Well, CVEMP is pathological in 57%, OVEMP 56%, pretty much similar. The most frequent finding is reduced or absent amplitude. But in some cases, you can have a prolonged latency, but it is, as we can see, less than in 10% of those patients. Here we have a woman, 40 years old. Her symptoms started recently, 6 days ago. She complains about slight instability, some positional vertigo with nausea, oral fullness, and tinnitus at the right side. And we have a slight gaze evoked nystagmus to the left. So everything looks like something wrong with the right ear. Positional tests are negative, ear gain reduced a little bit more at the right side. So considering symptoms and finding, and this audiogram, which is a little bit worse at the right side, we can conclude that something wrong with the right ear. And what when we do VEMPs in that patient? Normal response at the left ear, but look at the right ear. First trace, the amplitude is less than on the left side, but with normal latencies. But later on, second and third measurement demonstrated the latency leg, and here is, but on the left side, the amplitude latency are always pretty much the same in the normal values. So prolonged latency on the right side actually is it indication to perform MRI? Yes, it is. And in this particular patient, we found demyelinating lesions at cerebellum and also brainstem. So in patients with multiple sclerosis, we can have prolonged latency, reduced or absent amplitudes. And it doesn't correspond with MRI findings. What does it mean? We can record dysfunction of this reflex arc despite no visible changes at that part of a brainstem. And what does it mean? Well, actually, here VEMP find a very good clinical application. Here is proposed and very good in the clinical practice scoring system. 1 point if the latency is prolonged, 2 points if the amplitude is decreased, and 3 points if absent. It is a really good predictor of a disability scale, and the same authors find that the OVEMP is a better predictor than a CVEMP. And what about BPPV? Well, actually, VEMPs didn't find a place in this diagnosis. Actually, I must admit that personally, I usually don't perform VEMPs in BPPV patients, but as you can see from these studies, pathological values are present, not so rarely, and especially in ears with recurrent episodes of BPPV. Yes, I consider it useful in the patients with recurrent BPPV to check VEMPs, especially OVEMPs. We, as we mentioned at the beginning, VEMP tests type 1 receptors innervated by irregular afferents at striaula. And we saw that some patients with BPPV have normal OVEMPs. And so Hegeman asked a really good question. How many otoconia must be lost for abnormal VEMPs? And also, does VEMP response represents only a good or bad function of receptor cells? Or does we need intact otoconia to get the VEMP response? We know that for a sustained response from type 2 hair cells, which we don't measure by VEMP testing, we need for their good function a gelatinous layer with otoconia on it. So now it is for rethinking, and it is difficult to speculate how many otoconia need to be lost in order to cause pathological VEMP results. Here is a male, 38 years, with a history of positional vertigo, and he had a constant feeling of instability, like walking on a foam, and nausea when traveling. Vestibular findings are normal. At that time, positional tests were negative, V-HIT results normal, and oculomotor tests exclude central pathology. But he had on a Maddox chart some kind of hypophoria, left, that we measure vertical symmetry of bulbous, so hypophoria of the left, some kind of ocular torsion to the left, and slight tilt of the head to the left. So we can say that he has ocular tilt reaction to the left side, but not pathological values. Since ocular torsion is in normal limits, it is a slight head tilt, and with a cross-cover test actually is normal. Just measuring with Maddox rods, that means that vertical asymmetry is just slight. So we can see that in the normal individuals also, not pathological in pathological values. But how can we explain his symptoms? Actually, what is otolytic syndrome? It's described like postural unsteadiness, the word is rocking, patients have feeling like on a boat. Usually, those patients, because of a dysfunctioning otoliths, have recurrent episodes of BPPV. And here, in this particular patient, running OVEMP, we find reduced and absent response at the right ear and normal response on the left side. You see just one diminished amplitude, which is not reproducible. So right utriculus doesn't work well. So what kind of symptom would you expect from a patient with dysfunctional right utriculus? Other canals work, other ear work. So, and how can we explain his, let's say, slight subclinical symptoms of ocular tilt reaction, which is to the left side? In acute utriculitis, acute vestibular lesion, we would expect ocular tilt reaction to a side of a lesion. That means he has right-sided utriculitis, ocular tilt reaction to the right side. But this is a chronic, not acute. This is a chronic dysfunction of right utriculus. So probably because of dysfunctional, this graviceptive sensor, he has some kind of a slight compensation to a better working side, to a left side. Otolytic vertigo was described more than 20 years ago by Brandt. And here is a interesting study done by Murofushi almost 10 years ago in patients with tilting sensation. So he noticed that when a patient has a feeling of a lateral tilting, what does it mean? That means that patient have a feeling like a head is tilting in this plane. And he found that those patients frequently had abnormal function of the utriculus, abnormal OVEMP. But patients with tilting anterior-posterior, that means in this direction, he noticed that most of them had pathological values of CVEMP, that means that not good functioning sacculus. One more case. This patient complains of short spells of vertigo, repeating several times per day, and a constant feeling of a tinnitus at the left side. Also, left-sided oral fullness from time to time. If we look at the audiogram, is pretty much normal and not significant asymmetry. And what we should suspect what do you consider, short spells of a vertigo for a couple of seconds, frequently during the day? Vestibular paroxysmia. MRI is not a criteria for the diagnosis, but in this particular patient, it is documented that the ICA is in conflict with 8 cranial nerve on the left side. And on that side, we have some prolongation of the amplitude, and by MRI, we excluded MS or other central pathology. And regarding patient symptoms, which are recurrent spinning vertigo, less than 1 minute, stereotype phenomenology, and response well to carbamazepine and oxcarbazepine, we can conclude it's vestibular paroxysmal or neurovascular conflict. And Hafner measured VEMPs in those patients and found that 11 of 20 had pathological CVEMP values. And I can conclude that in a clinical practice, VEMP is very useful, especially in recognizing superior canal dehiscence patients, and also it help you in some form of vestibular neuritis, especially rarer form like inferior vestibular neuritis or isolated utricular lesions. And it is very good early predictor of disability in multiple sclerosis patients. Thank you very much.